Welcome to the webinar on silverdynamine fluoride transforming community dental caries programs. We have visitors from all over the world, and I know some of you, it's midnight or early hours of the morning in Australia, so thank you very much for staying up. My name is Professor Raman Bedi, and I'm chairman of the World Federation of Public Health Association Oral Health Group. Next. Okay, the next slide. So the Oral Health Working Group is starting a series of global webinars, and this is the first. So we want to say thank you to all our speakers. We want to say thank you to you for participating. And we also want to thank our sponsors, the University of Geneva and the Global Child Dental Fund and Colgate-Palmolive. For conflict of interest and declarations, I want to state that I have recently been doing some advice for SDI, an Australian company that produces Rivastar, which is an SDIF product. Also, Jeff Knight has done some consulting for SDI as a company. We're not aware of any other potential conflicts of interest. And today we will not be talking about any products, but purely silverdynamine fluoride as a whole. Also, we've agreed that this webinar will be made available free of charge on YouTube, and all the speakers have agreed that this recording will be freely available on the World Federation of Public Health website and other social media platforms. My name is Professor Raman Bedi. I hold a number of positions as Emeritus Professor at King's College London. I've mentioned I'm chairman of the World Federation Public Health Association's Oral Health Group, and I'm the chairman of the Global Child Dental Fund. The World Federation of Public Health Associations is an international not-for-profit organization based in Geneva. It has formal links with the World Health Organization, and it represents and has membership of over 115 public health associations from around the world. Next slide. We're delighted to have 4 international speakers with us. Dr. Rick Needleman, who is at New York University, and we'll introduce him formally in a moment. Professor C.H. Chu, at the University of Hong Kong, Dr. Jeff Knight, who's based in Melbourne in Australia, and Prateep Panatumvanit, who is at Thammasat University in Thailand. Our first speaker will be Dr. Rick Needleman. Rick has been a friend and a colleague of mine for a number of years and has been undertaking some innovative work with silverdynamine fluoride in the community. He's a professor at New York University and a co-director of the WHO Collaborating Center for Quality Improvement, Evidence-Based Dentistry. Next slide. C.H. Chu is a colleague, and in fact was one of my students when I was teaching at Hong Kong, and is a professor and associate dean at the Hong Kong Faculty of Dentistry. He's president-elect of the Southeast Asian Association of Dental Education. CH has been doing some remarkable work with silverdynamine fluoride in kindergartens. Next slide. Jeff Knight has been one of the pioneers of silverdynamine fluoride and minimal invasive dentistry. Jeff is based in Melbourne and is an international reputation and had a long history of working and developing silverdynamine fluoride initiatives. Next slide. Dr. Prateep Panatumvanit is another colleague and friend, and we have worked for a number of years in low-income countries looking at the best caries management processes. Prateep is the Dean of the Faculty of Thammasat University in Thailand and a board member of Thai Dental Council. He is a member of the WHO Advisory Expert Panel on Oral Health. Prateep has been pioneering and developed the whole concept of silver ART, and he will be sharing his experiences with us. So it's with delight I can now present over to you, Rick, to give your presentation on your experiences with silver diamine fluoride in the United States.
Thank you, Ramon. So where I'd like to start is a descriptive analysis of the problem. Next slide, please. In the US, how we've introduced silver diamine fluoride, and then our New York City and New Hampshire school-based caries prevention program. Next slide, please. So conceptually, the US has a significant caries problem as a developed country. On the x-axis, and this slide presents what the problem is. The x-axis is time from 2000 to 2014, and the y-axis is percentage of children with caries. The bottom blue line shows what's happened over the last 15 or so years. That percentage of children with caries has gone from about 30% to 20%. And the upper line, blue line with the open boxes, the percentage of kids with caries experience has gone from about 50% to 52%. That's caries experiences, untreated caries plus treated caries. The red line are the, in this country, the Hispanic Latino community with caries. So it has consistently been higher than the national averages. And what you see over the last 15 years is that there's been increased inequity. Now that's in spite of the fact that the US has gone from spending about $2 billion a year in 2000 for children's caries and to $15 billion per year in 2014. So we've gone up sevenfold, but we haven't decreased that much the number of the caries experience. And in fact, we've increased inequities. That's in spite of the fact that we have 10% more dentists and 20% more hygienists. So that's what the system is currently doing without SDF by implementing widely drilling and filling. Next slide, please. So here's another look at that. If we start at the structural determinants of health, at the top we have social determinants. At the bottom, we have person-based care. That's what people do at home. We have practice-based instruments. That's our drilling and filling. And that's what we've spent our last 100 years, but I've showed the last 15 years. Next slide, please. So what I want to focus on is program instruments, place-based caries prevention. I'm not going to talk about policy instruments such as sugar taxation and water fluoridation. I'm only going to focus on place-based caries prevention. In our context, it's school-based cavity prevention in elementary schools. Next slide, please. So what we did starting in 2003 is brought cavity prevention to kids rather than kids to cavity prevention. We parachuted into schools and we provided toothbrushes and toothpaste, fluoride varnish, glass ionomer, classic sealants of all pits and fissures, and what is called here therapeutic sealants. They're also called ART in most of the rest of the world, or the American Academy of Pediatric Dentistry calls them interim therapeutic restorations. What we attempted to do in our comprehensive prevention program is pick the most effective cavity prevention intervention for each category. So the data when we started from systematic reviews of randomized trials indicated that toothpaste, fluoridated toothpaste, reduces cavities by 25%, fluoride varnish by 40%, and glass ionomer sealants and ITRs by 80%. Our care is delivered by a hygienist working with a dental assistant. Care takes 15 to 30 minutes, and in this country, it costs about $70 all in. So $70 is for all of the people and all of the material and time. Next slide, please. This is a different look at the same protocol, just itemized it by primary and secondary prevention. So toothpaste and fluoride varnish reduce caries, again, by 25 and 40% on smooth surface. Sealants reduce caries on pits and fissures by 80%, and ITRs or ART reduce caries by about 80% on carious lesions. Next slide, please. And this is a high-level view of what we found after 6 years. In our population, 60% of kids had untreated caries, and over that time frame, we reduced that down to about 20% using just school-based prevention delivered by hygienists. Next slide, please. So in 2015, our Food and Drug Administration approved a use of silver diamine fluoride. So we began to switch gears, moving to what were called Carried Away version 2.0. Again, use parachuting into schools, now in New York City and New Hampshire, using fluoride toothpaste and toothbrushes, not fluoride toothbrushes, just fluoride toothpaste, fluoride varnish, and now silver diamine fluoride rather than glass ionomer. Care is delivered here by either a hygienist or a nurse working with a dental assistant. Time takes us about 10 minutes per visit, and it costs us about $25 per visit all in. So about 1/3 the time and about 1/3 the cost. Next slide, please. This is again, another view of the same thing of Carried Away version 1 versus Carried Away version 2. Again, looking at primary and secondary prevention, so you can see the comparison of the smooth surface, so that hasn't changed. Pits and fissures hasn't changed. We're simply swapping out interim therapeutic restorations and sealants using glass ionomer with silver diamine fluoride, and our hypothesis, as you can see from the table, is that they should be equally effective. Next slide, please. And this is our preliminary results. We had a 1-year pilot in New York City. We're currently in the 2nd year of a 5-year cluster randomized controlled trial with 15,000 children in New York City and about 10,000 children in New Hampshire. So about 25,000 children altogether. New York City is largely an urban, water fluoridated, Hispanic, Latino, Black community, low income. New Hampshire is largely a rural, non-fluoridated, white community. So we have truly opposite ends, if you will, of the social spectrum in terms of rural and urban, and very different socio-economic, ethnic populations. And we expect that that red line over the next 5 years will begin to parallel our experience in Boston. This is the largest clinical trial of caries prevention among U.S. school children in U.S. history. Next slide, please. Our preliminary modeling, and this is published in the American Journal of Public Health, our preliminary modeling suggests that universal caries prevention could eliminate 80% of children's caries and cost less than 1/5 of what Medicaid currently spends for children's oral health. That's that $15 billion that I shared with you. Medicaid is our national insurance program for children's health, not just oral health, but children's health. Next slide, please. Our modeling also suggests that it isn't relative just for children. It's implementable across the health spectrum, the age spectrum, from pregnant women to children to adolescents to adults to the elderly. Next slide, please. Thank you very much.
Rick, thank you very much for that presentation. There will be a time for question and answers later, but can I just, at this stage, ask for some clarification?
Of
the
course.
Difference between SDF alone as opposed to SDF and glass ionomer, what were your findings?
So that was on the slide with the red and blue line. We only have 1 year of outcome data for the silver diamine fluoride versus the 5-year outcome for the glass ionomer. And it looks like they're quite similar. At least they're trending in that direction, but it's too soon to tell.
The other question, and the last one at this stage, is that in many parts of the world, a toothbrushing scheme in schools is relatively commonplace. Would you advocate doing a toothbrushing with possibly fluoride varnish and SDF? Is there a synergistic effect of adding all three?
So that's a great question. There's the issue of residuality. That is, if you look at each one individually, toothpaste reduces cavities by, say, 25%. That leaves 75% untreated. If you use fluoride varnish alone, it's, say, 45%. That still leaves 55% untreated. So I think you need, and the data suggests you need all of it to work. Whether you need both silver diamine fluoride and glass ionomer is an open question. You still, either one has 80%, but whether they're additive or not is, we don't know. The suggestion is to make it simple. If fluoride varnish eliminates 50% and we just do fluoride varnish, how do we get rid of the other 50%? Well, let's say we use silver diamine fluoride. It's going to reduce 80% of that 50%. So you're still going to have untreated caries. So there's nothing that's going to be 100%.
Very good. Thank you very much. Our next speaker is Dr. Prateep Pantum-Bhanet, who is going to share with us his experience of. Yes, sorry, we're having difficulty connecting Dr. Cho, so we're just going to move on to Prateep. Prateep, would you like to present your work?
Yes, Raman. I will discuss with you this morning about the application of the silver diamine fluoride or SDF in the non-invasive caries management. Next, please. As you all know, as a public health people, you know that there are 3 levels of prevention. As Professor Niederman mentioned before, that you see that fluoride toothpaste may be considered as a primary prevention, but fluoride varnish can be as a secondary prevention. But as he mentioned, silver diamine fluoride can be also a secondary prevention. In my point of view, the tertiary prevention is something like ART or IPR in US or the smart preventive restoration, which I will discuss with you today. But many people now, they are trying to use silver diamine fluoride as a tertiary prevention as well. Next, please. As Professor Niederman mentioned also that the ART have been accepted well for a long time, I think more than 30 years up to now. And you can see that the use of the evidence-based review of literature in 2018 mentioned that the ART has been supported by strong evidence, which is ART is a selective remover of the firm dentine. But also we developed from ART to SMART, which is can also support by strong evidence, but that is for deep cavitate and cavitated lesion by using selective removal of soft dentine in that case. As you know that ART or SMART, for my own consideration, I think this is a tertiary prevention. Next, please. So we think that as Professor Nilan mentioned, the world is changing and the dentistry caries is also changing. The paradigm in cariology is changing from the deal and fill restoration to maybe now we are thinking that we can use seal and heal operation, which is more simple and more practical and also painless to be more acceptable for everybody. Next, please. I just would like to mention to you that ART have been using for more than 3 decades since 1987. But now we would like to move from ART to SMART development, which is about 25, 30 years after ART. But it's still we using still the same concept of hand instrument only. But SMRT we use a partial carry remover or selective remover to solve dentine. And in SMART, we also using capsulated glass ionomer, which is, I believe, it will be better consistency and better power liquid ratio, which will give a better result in restoration as well. In ART at that time, we aim to for the permanent molar, but at the primary school student. But now in SMRT, we are aiming at the primary dentition at the preschool student, which we know that now early childhood caries in the preschool student is very high. So I believe that SMART might be more practical in the young children. Next, please. Actually, right now there are two models of SMART preventive restoration. The one that I'm using in the Asia, in that area, we call simplify, modify, traumatic restorative treatment and technique, or SMART, which consists of 2 steps: partial carry remover or selective remover to soft dentine, and fill up with capsulated gossamer cement. But recently, in the group in the California group, they modify. They're using they call it silver modified ART or silver modified traumatic restorative technique, which they apply silver diamine fluoride to the dentine caries and fill up restoration with the glass ionomer cement as well. So there are 2 steps. As Professor Niederman mentioned also, whether these two steps is better or not, we have to prove. It's better than just glass ionomer or better than just SDF or not. And they take time to prove on that one. Next, please. But what we thinking that SMART in both technique is also practical, especially in the early childhood caries in preschool children. Simplify, modify ART or silver modify ART is now using in many parts of the world in both techniques. But in my opinion, I think that a root caries in elderly patients, silver modified ART might be a better one, because as you know, the response of the pulp in the elderly person is not as good as in the young children. So with the silver diamine fluoride, maybe it might have better effect in this group. Next, please. Why is it the silver ART is have more advantage than just the glass ionomer itself? As you all know, that SDF is a 38% silver diamine fluoride, which comprise of 24 to 29% silver and 5 to 6% fluoride in the alkali solution PS10. Silver ion, it has like other metal antimicrobial. This is the effect that we believe that with the silver diamine fluoride application, no matter just on the dentine, caries dentine, so they will prevent the plaque formation, and then they will also kill the bacteria at that time. But at the same time, glass ionomer, as you all know, that is a sealing and bonding with the and dentine, and also glass ionomer has a fluoride release. So these two together, they make things more simple, practical, and acceptable technique, especially for young children and also maybe for elderly patients as well. So this is a concept that we think that we call is a no injection, no drill, and no pain procedure, which might be more practical in the community as well as in the children and elderly. Next, please. So I believe that with this non-invasive caries management, silver diamine fluoride has a role both in the secondary prevention and as well as in the tertiary prevention. The secondary prevention, as we just used to silver diamine fluoride to paint on the top of the dentine caries to stop the progression of the caries. But the tertiary prevention, not only to stop the progression of caries, but we have, if you add up of the glycosylated cement on top of the silver diaminal fluoride that have been using a part of SFART. In that things, we can think that we can restore the function of the teeth as well. But as I told you that there are two ways of smart preventive restoration, either with silver diamine fluoride or without silver diamine fluoride. So this is the times we show that we say any better on these two things. That is my message to you this morning. Thank you.
Pratik, thank you very much. And Rick Needleman's also shared with us that there's the evidence for SDF as opposed to silver diamine fluoride is still unknown and is developing. But practically, in your experience, what have been the benefits of using a silver ART over just SDF alone?
I believe that if it is the cavitated dentine, if it is not so deep or it's just the beginning of the dentine cavity, the SDF alone might be practical because it's something like, as I mentioned before, that this is a secondary prevention, just painting to stop the progression of the caries, which is have been proved well in many countries. You know. But in terms of the deep caries or big cavity, I mean, which is only the painting of the SDF alone, it will not the cavity still be there. So in that case, might be top up with glycosylated cement might be better. So this silver ART might be better in terms of the big cavity or deep cavity. In that case, you can restore the function of the teeth and remove the caries and also remove the bacteria from the cavity as well. So it depends on the size of the cavity and on the lesions, I think.
It does. Thank you. I think today's focus is very much on community programs. And I agree with you, in the clinic, sometimes it's easier after you put on silver diamine fluoride to stop debris into a large cavity by placing glass ionomer. I can see on an individual clinic basis the advantage of that. But can you just share with us briefly before we move on to the next speaker, the difference between using silver diamine fluoride and glass ionomer, the silver ART, as opposed just to SMART?
Yes, in our part of the world, in Asia, because as you know, the ECC is very much prevalent especially in European countries also. So we using only simplified, modified ART or SMART with only remove caries, partial caries remover and glycosylated cement only. And we think that may be enough because we have been working for a few years, 2-3 years already. We have a result for 2-3 years showing that it's quite similar to Professor Needleman data that is reduce the caries might be about 70 to 80%, something like that, with only with SMART glycosylated cement only with our SDF. But since now the silver ART has been using in USA and in some part of the world, we still have not have a comparison about the result of that too. But definitely silver ART might be a bit more expensive because you have to use both silver diamine fluoride and glycosylated on the same cavity. But we have to see the cost benefit as well as the caries reduction in this in comparison as well. We need more study to say something about that.
Pratik, thank you very much. And we have Professor C.H. Cho, who's now joined us. C.H., welcome. Thank you for persevering to get the connection. Can we ask you to give your presentation on your experience of using silver diamine fluoride in Hong Kong?
Can you hear?
Yes, we can hear you, CH.
Okay, so thanks for inviting me to join this webinar. So next slide, please. So I would say in Hong Kong, the work is not a person, it's a team. And the first slide I'm showing to you is the team member that who contribute significantly on the laboratory study. Dr. Mei Lei was a PhD in Hong Kong U. Now she is a senior lecturer in the Otago University. Actually, Mei has found out that the silver-diamine fluoride is a very powerful reimmunizing agent to generate hydroxyapatite crystals on the lesions, cavities lesions. And also she found out also this silver-diamine fluoride can inhibit the collagenase activities of dentin to prevent the damage of dentin by these enzymes. And also may also contribute to some studies on the antibacterial effect and show that SDF is very powerful to inhibit the activity of strep mutants and lactobacilli and Actinomyces. So in the middle is Irene. Irene actually contributes significantly on the inhibition on the secondary caries lesion, in particular under glass ionocements. And then she is now working in China as an assistant professor. And lastly is Dr. Oli Yu. And actually, she also found that very significant finding is the silver. Actually, the silver crystal actually can absorb into the hydroxyapatite crystal that may strengthen the ability of the minerals on the inhibition of the caries. So these are the person I think we should acknowledge for the contribution in the laboratory studies. Next slide, please. And then also we have a team of people doing clinical trial, and Dr. Tammy Dong Tip, actually Tammy is working with Professor Pardip in Thammasat. She was the Associate Dean in Thammasat University. She came to Hong Kong and actually conducted quite a number of significant studies on clinical trial, and also analyzed the side effect on a 30-month clinical trial on the what are the complications of SDF on preschool children. And what she has found out is there's no significant side effect or permanent side effect on preschool children over 30 months. And also Dr. Dong Pong also contributes to significant studies on clinical trial on SDF and showing that this is effective in arresting caries. The next one is Sherry Gao. Sherry Gao actually also found out that SDF is effective in arresting caries, which can be as good as using silver nitrate and sodium fluoride varnish. And Dr. Ji is now is working in China. What she found actually, if we use annual application of silver-diamine fluoride, which will be effective, but the effectiveness will be better if you do this treatment twice a year. And finally is Dr. Marcus Fong. Dr. Marcus Fong actually applied SDF on children using different concentration, either 12% and 38%, and also try to look at it applying the fluoride every 6 months or every 12 months. What Dr. Fong found out that actually 12% is not as good as the 38%. So from his study, we will recommend not to use 12% in preschool children to arrest the caries. Every 6 month application is sure better than every 12 months. But if you, from the public health perspective, if we have limited resources, we'll recommend annual application will be more cost effective based on Dr. Fong's study. So this summarizes some of the projects and some of the conclusion that is from the Hong Kong U team. Next slide. So I want to, I think we, most of our paper is published online, then you can Google it, and actually most of the paper are open access. Now today I would wish to share with you some of the results that we are doing not the clinical research, but we try to translate our research finding into community engagement and doing community projects. Actually, when we start the project is back to 2008. We start with about 3,000 children on 19 kindergartens, and then we gradually grow to 100 kindergartens to serving more than 20,000 children in the past 10 years. I would say for the past 10 years, there's no significant side effect that have been observed. That's in talking about more than 200,000 children that received the treatment. We are going to publish the results soon. What we also found is not only the SDF treatment, we try to build a program that's to 3 parts. On one part is to screen out the children with caries, then we apply SDF. We also educate the children about caries. Also, we provide education to the teacher so that they can deliver the message to the student from time to time. And finally, we also educate the parents talking about the importance of good oral hygiene and make them aware of the tooth decay problem that may affect their children. Over the 10 years, we found that there is a significant reduction of the new caries in these kindergarten children. While the Hong Kong caries rate remained more or less the same as about 50%, we have more than 10% reduction of the caries rate among these children in our cohort. This is a very encouraging findings. And I want to share with you among those children that's joining the program, most of them, they have no problem with the discoloration because we inform them the result. Okay, that will be stained black, and that will be one of the indication of caries arrest. And the parents, and both the parents and the school has responded positively to the program. And from the success of these projects, starting from a seed fund, which is less than $40,000 US, we slowly grow the project with support from the non-dental organization. We also get some support from industry to promote the projects. Next slide. So this one. I want to say some major outcome of these projects. First, there is a significant caries reduction, which is more than 10% of those people, those children who join the project. More importantly, for those children receive SDF, there's less pain. A lot of the children have no pain and no reduce the chance of sepsis, reduce the infection on these caries teeth. And the caries can be arrested at an early stage to prevent from progression. These are the major outcomes. I would be very happy to see these children are free from pain and infection because of the SDF treatment, plus the change in the diet pattern, and also the improved oral hygiene through oral health promotions. So in this slide, you can see we are good, not only doing examination, applying SDF, we also provide oral health education to the parents and the children. And also we implement this oral health education program into kindergarten so the teacher will deliver the message from time to time. Next slide, please. So this slide shows the major funding that we have got. And you can see the first project when we started is a seed funding of less than $40,000 US to have a pilot study to see the effect and also to evaluate the parents and teacher response to the project. And subsequently, we get quite a number of funding from the UGC General Research Council that the funding will allow us to conduct a number of clinical trials that support the PhD student that I've shown you the team to get more projects. And then the success of this project has been expanded to 100 kindergarten by SKE Medical Foundation. Hong Kong, there's 1,000 kindergarten. So the SKE Foundation will scale up the project to about 10% of the of all the children in Hong Kong. And I'm glad to say that the Hong Kong Jockey Club finally actually see our result after 10 years for the success. So Hong Kong is going to launch a project to serve all the 180,000 children in Hong Kong. The university got a $7 million grant to do the project for 3 years. And we are glad that the project is not on the research, but translated into the community and benefit to the children of, all the children in Hong Kong. So that is, next please. So this is summarize what we want, I have said. Thank you.
CH, thank you so much for that. When I visited you in Hong Kong, what I noticed and was really impressed with is how the community has responded. Politicians, funding agencies, all rallying around because they see young children in kindergartens who don't have pain and sepsis, and they see a reduction in new cavities. Do you feel that's one of the main outcomes of this translational research, is the way the community have rallied around and support the research at Prince Philip Dental Hospital?
Yeah, actually, Raman, one thing I want to share with the academics, so if you ask for funding from the university, even for the Grant Council, the amount is limited. If the research is, good, benefit to society, actually you have larger opportunity to get larger funding to benefit all the children. This is very important and is a significant impact to the society. So I would say I'm glad that when we scale up the projects, we allow these different stakeholders of the community to join the program, and so that they will support the project. So at the end of the day, will be benefit to the children. This is something I really want to share and become one of the main mission of our university, is the community engagement to benefit to a greater community in Hong Kong.
Great. And finally, CH, the other thing that impressed me was the number of children whose parents who don't traditionally take their children for dental care. Our 2-year-old and 3-year-olds who are always notoriously difficult to get them, but they seem to have embraced this caries prevention program. You know, and I've known in some countries people call it dental vaccination, come and have your child dentally vaccinated, or the magic solution. Has that been one of the main encouragements to your team, is how non-traditional dental attenders have been coming into this program?
Yes, surely you can see actually our participation rate is almost 90%. So that means almost, I would say most, if not all, the children with tooth decay are willing to join the program. In particular, when we scale up, they see the effect. There are comments from some parents and school that join the program that will be helpful to promote the project. And we will see, I would say in the past, those worry about the aesthetics, the concern, basically is not evidence-based. This community program has shown that if you explain clearly the outcome, most parents and kindergarten would join the program. So we have the realistic data to show that actually this is one of the effective way and a very cost-effective way to control tooth decay for the preschool children. While the traditional care basically is so expensive and also create a lot of dental fear to the child. Actually, we are assessing also some of the other outcomes such as dental fear, and hopefully we'll try to report it in future.
Good, thank you so much, Serge. Good, we'll move on to our final speaker, Dr. Jeff Knight. Jeff, you're going to share with us some of your experience in Australia.
important that the pharmacological management of caries has become, apart from the, I suppose, the digitally inspired amputation of teeth that so many of our colleagues get involved with. And I'm very honoured to be part of this program. Have the next slide, please. Managing caries, basically, it makes it available to so many vulnerable people. Someone goes into emergency ward with a high caries rate, they can be triaged, and certainly the caries, if they wish, of course, can be deactivated by the use of an application of silver diamond fluoride, so they can leave that emergency room without any caries. And I think that's such a wonderful thing, because so many people, certainly here in Australia, they get on this bandwagon where they're in and out, there's long waiting lists, and all they ever get is emergency care. We have the next slide, please. The other thing, it produces wonderful efficiencies in managing caries that you really can't do in a normal dental practice. First thing, it reduces the waiting time, because there's really very little need to do any sort of tooth preparation, and that's a very significant fact when certainly then here in Australia that the health system is under tremendous stress, or the public health system is under tremendous stress dealing with caries. And of course, it dramatically reduces the need for general anaesthetics in young children. This is one of the really sad things that goes on, because these kids that can't be treated, they're sort of funneled off to a general anaesthetic, which certainly can't be good for a 4-year-old or any child. And by just explaining to these children that what's going to happen using minimally invasive techniques, it's wonderful to be able to take children off the general anaesthetic list, and of course it saves the government a lot of money as well. And the final sort of benefit is this it's a simple treatment protocols, and this facilitates providing care in remote locations, and I don't mean overseas, but remote locations in nursing homes away from the dental office, and in schools where dentists can go in and triage these children on site, and again expand their delivery of dental care and reduction of caries at a significant rate. We have the next slide, please. This is an unpublished study out of the University of Melbourne, and it was Dr. Rani Yahweh of the Dental Health Service Victoria put this together, and it's a study on 4-year-old children, many of whom were prescribed a general anaesthetic. And so there were a total of 114 children, and half boys and girls. 12 were put down for a general anaesthetic. It was a combination of SDF application as an adjunct to twice daily brushing with the fluoride toothpaste, and also comprehensive diet counselling. And the 6-month results are really very encouraging. Firstly, there was a 78% reduction in active caries, and that goes along with what other studies are finding, about an 80% reduction in caries. 99% of the general anaesthetics were avoided. Only one child on the GA list needed an anaesthetic, but the children in that group may have well needed an anaesthetic as well. So it's this dramatic reduction in general anaesthetics for children, which is so good. There was an increase in the OHIP score, which I believe is a self-reported quality of life. I'm not quite sure how 4-year-olds manage that, but that's still, kids feel better about themselves. And the other thing, of course, is, as Dr. Chu said, very high parental acceptance. The parents of this program are very pleased to have their children involved in this type of care. Have the next slide, please. Okay, this is a study, again unpublished, that's going through the system. It's done in the Dental Health Services of Tasmania, and the aim of the study was twofold. Firstly, to compare the 3 monthly treatments of sodium fluoride varnish against the one-off annual treatment of SDF, and the other aim was to compare the cost effectiveness of SDF against standard dental care. And they were children 8 years or less with asymptomatic caries, and they were randomly chosen through the system. Now, the study was disrupted by having to stop the fluoride varnish, as it was significantly inferior to SDF, and they thought there was ethical constraints in continuing with this study if the SDF was so effective. And the other thing is that the treatment cost of FGF was dramatic reduction in treatment. It's similar to Rick's study. The cost of doing a restoration per child was 27 Australian dollars. With the cost of standard treatment per child, again, these results are skewed. because you've got a situation where there are other things happening with the children, but you can see the difference of about nearly $1,500 against the cost of $163 to treat a child. So there's huge economic benefits as well as the benefits to the children as well with this type of treatment. And the outcome of this is that SDF is now used in every government clinic in Tasmania. It was started off in just the area around Hobart, and once they saw how effective it was then expanded to every clinic. Can we have the next slide, please? Okay, so where do we go from here? Where's the story? Where's this journey taking us? Well, there's a number of issues I'd like to talk about. The first thing is toxicity. A lot of colleagues I've heard say, "Oh, that's very 38% silver fluoride. That's very toxic. You shouldn't be using that in children." But there have been a number of studies that have shown that. I think there's one on the short-term serum pharmacokinetics of one-off treatment of silver diamine fluoride was that it was well below the US EPA reference dose. And they said the silver was slightly higher, but you'd need a lifetime application of silver to become really toxic. So I think it's been well and truly put to bed. I've certainly seen no adverse signs, but I've been using the material now for nearly 20 years. And it also supported by the studies that have been done looking at this. The eschar that formed, quite a high pH of SDF can burn gingival tissues. And I had a dentist come up to me at a seminar once and said, "I'm not using this material anymore." The whole palate went white. And I said, "What were you applying it with?" And he said, "I was using an eyedropper." So obviously, you apply it to where the caries are. You only need a very small amount. You dab it on the caries with a microbrush, and that's it. And keep it away from the gingival tissues. But if you do get a caustic burn, you get a white eschar that forms, and certainly a couple of hours later, the escar's gone. And I've never had any problems with children that have come back with ongoing issues with application of silver fluoride. Fluorosis, there certainly be concerned that the inadvertent ingestion of high dose of SDF can cause fluorosis. And there was a study done in Western Australia, which apart from showing how good it was, this was suggested that the dose was so high that it could cause fluorosis in children. And as a result of this, the Western Australian government, who was using it very happily in their dental clinics, stopped using it. So I think now that I've sort of done a look on PubMed and Medline, and there's certainly, I can't find any published stories on published data on fluorosis with silver diamine fluoride. The other issue is the 80% effectiveness. I think we need to look for the penicillin type effect, something that we can apply, and we can increase it to the effectiveness. So certainly, you never get 100%, of course, but certainly something above 80%. Say with an annual or biannual application, and make the material more effective. And the final thing that I think we should be looking at is sustaining. That currently, the SDF application is limited to the public health system, deciduous teeth, and geriatric root caries or clinics or geriatric clinics, and it's therefore there's no application for this into the general area of general dentistry. So that's something else I think we should be looking at. Can we have the next slide, please? Okay, so I think the aim of the whole thing is to what I'd like to see is bring SDF into mainstream dental care across all parameters of dentistry, because I think that the pharmacological management of caries is just so much more important and makes so much more insensitive than the antithesis of the amputation model that so many of our colleagues are pursuing. So thank you for Raman for that opportunity to speak.
Good, Jeff. Thank you very much for that. I suppose one of these studies, the alarming studies of reduction in general anaesthetic, is seeing the child early enough. Because silver diamine fluoride is going to arrest the decay and stop the progression that will then lead to sepsis and pulpal involvement, etc. So the critical thing is seeing the child early rather than seeing a child that's presenting with abscesses or with pain. How did the Australia experience manage to get children early enough for them to come and have this treatment?
Well, that's the important question, of course, because the issue is that if you have a symptomatic lesion, silver diamine fluoride is not successful. I've used it sort of with trepidation over a number of cases over the years. Sometimes it doesn't, and of course, if it doesn't work, it's the silver diamine fluoride that causes the problem. I think it's only a matter of education and getting kids into the dentist as quickly as possible. It's an education system. Sort of we need government a government sort of dental health education program. Dental Health Week, the Dental Association does what it can, but I think that what we really need to do is get these kids in as early as possible so we can prevent the problem before it becomes symptomatic, and therefore you need other more drastic measures to treat it.
And I think that's one of the encouraging things of an integrated healthcare approach, because children are turning up to general medical practices for vaccinations, and early referral would be very useful when they're detected there. And the second, I like the idea of the dental vaccination. Parents identify with vaccinations of early children and come and have a tooth treated and managed and strengthened is in every aspect could be sold as a dental vaccination. But Jeff, just finally, how do you think the effectiveness of SDF can be improved?
Well, I've been using this in general practice, but also out in the field in East Timor and Papua New Guinea. And I found that the prior application of phosphoric acid beforehand, no one seems to be using phosphoric acid, but it's a wonderful way of cleaning a lesion. It opens up the dentinal tubules, and it also dissolves the tooth mineral and exposes the protein, which again allows the silver diamine fluoride to actually sort of attach to the carious dentine, which is actually infected with bacteria. So before I use the material now, I tend to use a slightly longer etching time, and I find that very effective. And it surprises me really why no one else appears to be using an application of phosphoric acid before the silver diamine fluoride.
Okay, well, thank you very much for that. Thank you to all the speakers for that. Now we're having a more open discussion, and people that are viewing this have been sending their questions. So I'm going to read out some and then ask any one of the panelists if they want to discuss. There have been a number of questions questioning the toxicity, and one of our participants have asked, if several teeth have to be treated, is there not concern that young children will have an overdose or there'll be some systemic effects of the SDF? Would anyone like to comment on that? CH, do you want to unmute yourself? Is there concerns in the kindergarten studies that you've done that if multiple cavities have to be treated with SDF, there would be some concern about toxicity?
Actually, we just apply SDF to the caries lesion. According to we don't receive any, over the 10 years, I would say we never receive a single case that with a severe long-term complications so far. This is what in our protocol. Actually, we apply almost all the caries lesion onto our children group.
Okay.
So actually, we are going to analyze the result and publish it later on. Okay. But as far as I know, yes, it's a very highly concentrated solution, but you look into the amount of fluoride applied. Actually, we have a laboratory study. Actually, the amount of fluoride we apply is less than sodium foil varnish, because varnish is fake. When you apply a application of foil varnish, you did apply quite significant amount of fluoride to the caries lesion compared with the, the solution that we applied to a single cavity. So we did have some data to show the amount of fluoride we apply per application of SDF is actually lower than the SDF, lower than the sodium fluoride varnish.
Okay, good. Thank you, CH. Does anyone else want to comment on these toxicity concerns? No, I've been using SDF for over 5 to 6 years, and I've had no issues at all with regard to toxicity. Another person participating has asked the question of using SDF and people's experience with seniors, with older populations. Has anyone would like to comment on that, about the value of SDF in care homes, in domiciliary visits? Jeff, is there, so you need to unmute yourself, sorry.
Okay.
Sorry, Jeff, you need to unmute yourself, but we were asking a question about experiences with seniors and in care homes and domiciliary visits.
Yeah, well, I've seen it mainly in general practice. I see a lot of older people in general practice, and again, that you're reluctant to do too much for them, particularly if they're quite ill as well. And the benefit is that I just apply I etch it first, apply the silver diamine fluoride. That has dramatic effects, particularly when that person with xerostomia, and they can come and see the people's mouths disintegrate in front of you, and in 3 months' time they've got a whole new raft of cavities. The silver diamine fluoride is very effective at actually sort of arresting certainly root caries in elderly people.
Sure, thank you. Okay, Rick, can I ask you specifically, there's a question here that someone's asked about, is there any place for a traditional school-based service? I think they are referring to the fact of visits to schools to provide traditional care in the normal way. Do you feel the evidence base now is sufficient to discredit that type of approach?
I hate to say that there's evidence to discredit something that we've done for 100 years and create a firestorm. That said, I support Pratik's notion of moving from drill and fill to seal and heal. The data does indicate that once you start drilling and filling, those fillings are not permanent restorations. They last 5, 10, 15 years, and then they need to be replaced with larger fillings. So that ultimately, once a patient or a dentist starts down that path, the benefit for the dentist is an annuity. That patient, if they keep coming back, that dentist is going to have an annuity replacement, and they're going to make more income. So that's all to the good for the dentist. That's not to the good of the patient. So my ethical, moral approach to this is to continue to do prevention. Glass ionomer can be applied without any drilling and filling and maintain the coherence of the tooth. So from a patient's perspective, although perhaps not from the financial perspective of the dentist, I'd advocate for the MID, for the minimal intervention, and replacing it without any drilling. So while I said I wasn't going to jump into a firestorm, I'm a huge advocate for minimal intervention versus intervention.
Good, thank you. We have actually a comment who's asked the question that whether all children, if they have cavities of young children, who I think they're referring to preschool children, the first course of treatment should always be silver diamine fluoride until the dentist is confident that the child will be able to have a more traditional restoration. Prateep, do you want to just comment on that? Do you think SDF should be the first line in the treatment strategy for very young children?
I think it will depend on the severity of the lesions, because right now we can have a system to make an early detection. There are some early caries like the white spot lesion. SDF might be not really necessary, but I think that SDF it will have a good application when the caries come to the dentine, especially. So if it comes to the dentine caries, the SDF might be a good way to stop the progress of caries in for the future. And so I think the dentist or the dental nurse should be a bit more careful to make the early detection, so that for early prevention. But what kind of prevention? It depends on the kind of management that will be better for the children. But it can be used in the young children as well, if the caries is up to the dentine caries. I think SDF is still very safe to use in the young children, I believe.
Yeah. Someone has asked on developing that is that the Hall technique is being advocated. This is the technique where you place stainless steel crowns on symptomless primary teeth that have large cavities. And I suppose the question is whether SDF should be used in the first instance before putting on a Hall crown as a technique. Jeff, is there any comment you want to make on that?
Am I unmuted?
Yeah, you're unmuted.
Hear me? Okay. Yeah. Look, I've seen a lot of kids get these Hall crowns, and I think it's really important to the whole idea is to do as little as possible to get the effect you're after, and putting on silver diamine fluoride, certainly with a glass on a cement overlay, and this is the sort of thing that I've been doing with a team up in East Timor and Papua New Guinea, and it doesn't create a restoration if you just get a bit of Vaseline on a glove and just smear it over the surface to keep it out of the occlusion. You're going to get a few food packs, but you don't see children coming into emergency clinics with food packs, where you certainly see kids coming into emergency clinics with dental abscesses. So if you can do this, if there's a problem and the tooth sort of keeps disintegrating, then go to the Hall technique. But the Hall technique was developed before the advent, or before we were actually realised the benefits of silver fluoride. Yeah. So from every aspect, the delivery of the cost of delivery of care to the ease of application, many kids generally can have a general anaesthetic to put a Hall crown on. Yeah. So I would advocate firstly, do what you can first with silver diamine fluoride with a glass on a cement overlay, because I think that's a permanent, or not it gives a better outcome than 80% that we just get with silver diamine fluoride by itself. And then if problems develop, then go to the next technique, which is the Hall technique.
Okay, thank you. There's a question here about children with disability, and I'd look to the New York experience and Hong Kong. Did you encounter the acceptability or the impact that silver diamine fluoride had on children with disabilities? Was that part of the program? Rick, was that part of your New York program?
We have integrated, New York City and New Hampshire, where we're working, integrate children with disabilities. They mainstream them, and we're treating everybody similarly. Obviously, children with disabilities take more time, but it's equally effective from what we've seen. So there isn't any differentiation between mainstream kids and kids with disabilities. The biology of caries for all people is the same. So why would it be different for kids with disabilities?
Absolutely. Thank you. CH, your experience in Hong Kong?
Actually, we are serving mainly for healthy kids in the kindergarten. So I agree with Nick, but to be honest, I don't have much evidence to say that. One thing I want to point out that SDF is effective, but it is also important to improve the oral hygiene and also to make sure that the children are away from the carcinogenic diet. Caries is still, behavioral disease that because of the poor oral hygiene with, unhealthy diet. So SDF is great, but it's but be complement with other factors to make it successful.
Good. Yes, I agree with that. My experience in the clinic is if a child comes with cavities, a young child, then the focus of the conversation is all about the treatment. The parents want the treatment. When you actually use SDF and arrest the decay, you actually have the headroom to start talking about more important things like prevention, about sugar, caries risk assessments, because the focus has gone away from managing a child and restoring a decayed tooth. So I think SDF is very valuable in the first instance in that case. Good. Can I ask all the speakers to just comment on why it is, do you think SDF has not been widely used as much as it should be do in community programs? We have large numbers of community programs, caries prevention programs, but SDF is still, I suppose, not on the top of the list for people to introduce. Do you feel it's because the research is still emerging, or do you think there are other reasons? Rick, what do you think?
In the US, concretely, the payment system is not caught up with the clinical knowledge. We do not incent in the US for prevention, we incent for intervention. And we have a 100-year-old industry doing exactly that. So in New York, we don't get reimbursed for doing silver diamine fluoride. In fact, for fluoride varnish in New York State, you only get reimbursed for fluoride varnish for kids up through age 6, not for children over that. So that's a disincentive. In New York, I think it's $30, $35 for a prophy, which has no impact on caries. So the incentives are totally awry, financial incentives. I think if clinicians got paid for prevention and for health, we'd have a different approach or a different behavioral approach by clinicians.
Okay, well, thank you. CH, in your experience, this widespread kindergarten provision, has that translated? Do general practitioners now are embracing SDF more in Hong Kong?
Yes, we are promoting, but I would say professionals sometimes will not take up a new strategy very quickly. So going back to my first study, actually is 2004. And you see how many years it takes before it's widely recommended, even in the United States. It's more than 10 years. So I think it is more important to share more information through different channels to let the our colleagues to know that there is a new strategy for the caries management. I think that is important. When we want to talk about the effect of these products, I think it's again very, very important that to make sure that caries prevention is a holistic approach. It's not just the SDF. Otherwise, it may backfire the effectiveness of the SDF. That is, I think, the key message I want to share. It's a very powerful caries arresting agent. And it's also a very powerful anti-hypersensitivity agent. So that's why I think it is very indicated, it's very appropriate to use on young children. This is non-invasive, painless, simple technique that can stop the pain, reduce the sensitivity, and arrest the tooth decay.
Very good, thank you. Pradeep, your experience in Thailand, are general practitioners using SDF? I know the community programs do embrace it, but is this being translated into clinical care at the practice level?
Right. I think SDF is for the community is very clear because it can approach many students, many people at the same time. For the general practitioner, as Professor Chu mentioned, we need more information from everywhere. Recently, I just read the FDI policy in 2000 this year, just last month in San Francisco. They also mentioned that SDF is one of the options that should be considered for the general practitioner, the dental school, and the public health to be used. And a message like that, I think, is very powerful for the dental association to take away, and for the dental school and to teach more in this area. And it's, as Chu mentioned, Professor Chu mentioned, I think it takes time, but I think it will be in the mainstream and not so far, I think.
Okay, thank you. Jeff, in Australia, your experience of general dental practitioners using SDF?
Well, SDF virtually was first used in Australia by Graham Craig, came back and did a PhD in the 70s. And it was just starting to get legs. It was being used in the West Australian Public Health Service. And then this paper was published suggesting it might cause fluorosis, and that just shut the whole thing down for a number of years. And it's gradually coming back again, and there's interest in it. But I think certainly that the point that Rick made is that there's no remuneration for it. Dentists are very loath to provide the service. There's the health funds certainly have a large input on the fees that dentists charge. There's a lot of corporatization going on, and that's an issue as well. And the other interesting thing I found with I was going up to Timor-Leste with a group, and I bought some silver diamond fluoride with me. And I was painting around. There was a bit of interest, but nobody was really sort of taking any notice. And it wasn't until the next year that went up there, and they were saying, "Look, we've got these strange sort of teeth. There's these huge lesions, but they've gone black and they've gone very hard." And we were putting glass ornament cement over the top, but of course the glass ornament was washing off. I think even if it's only there for a short period of time. So it's a combination, I think, of the dentists really don't. It's slow to take off about. You can talk about the benefits, but you need to see the benefits, and therefore they're slow to take on the new technology, particularly when they've been trained in a particular way. Because dentists are told when you leave dental school, you do this, you don't even think about doing anything else. And also, I think it's the constraint that the dentists don't think they're going to get remunerated for providing the service.
Okay, thank you. There's a question somebody's asked with regard to deep cavities and any concerns you would have about a cavity being close to the pulp and applying SDF. Pradeep, would you have any concerns if there was a deep cavity and you think there may be close to the pulp?
As you may know that recently there is a group of the international caries remover consensus meeting that they said that if there is a deep cavity, and so far if it's not yet exposed pulp, it still still be good that the pulp is still vital and can respond well. So in that case, I think so far I think the SDF can still be applied to that area, because SDF is good for the for remove bacteria in that area, and also the fluoride in that area can enhance the remineralization behind that. I don't think that there will be any effect to the pulp so far, but we need evidence in that case. But I think maybe Professor Chu can mention more on that one. But to my experience, when it's a deep cavity, we still use the SDF to paint on it before we put on the glass on top of that one. We're still using that as well.
Okay, I do. CH, in Hong Kong, if you have large cavities, was there any protocols with regard to the placement of SDF?
Actually, it's very difficult to judge what is deep, what is not deep. So basically, in our kindergarten, we just apply SDF to those dentin decay. So for enamel, actually, we do put SDF in most of, if not all, the SDF. If the children are cooperative, then our survey found that there's no significant increase in the complication among the children. That's what we found. And actually, this is published in the JDL. Then, anyone who are interested can log on to go into the details of the different types of complication. And we do not find a significant increase of the complication after SDF application.
Okay, I agree. Rick, there's a question here about, do your nurses or your therapists, does a dentist determine the diagnosis, which teeth should receive the SDF? Or do the nurses make that decision when they examine the child?
We have a blanket approval. So a nurse under indirect supervision and indirect approval of the dentist, because we have to have a supervising dentist or a physician, or interestingly in New York, a podiatrist. So talk about non sequiturs. A podiatrist in New York can approve a nurse or a hygienist applying silver diamine fluoride. So the nurses and the hygienist are doing the assessments of whether there's a carious lesion and applying fluoride varnish. In New Hampshire and Massachusetts, no dentists are involved in doing the assessment of whether there's caries.
Okay, thank you. Okay, thank you. I'm going to give each one of the speakers just a few minutes to do a take-home message. What would be the take-home message you would give to this global community about SDF and community programs? Prateep, I'm going to start with you. What would be your take-home message from this webinar?
I would like to propose that the SDF is a good option for the community, especially in the community where there's a high prevalence of caries, both in the early childhood caries in the preschool children, as well as in the root caries in elderly. It is practical and easy to apply. And I think this is the way that we will changing the attitude of the people to the dentistry, that this can be what we call no pain dentistry. And it have a good power and very powerful for the prevention as well as a part of restoration as well. So we can apply SDF in both of the secondary prevention and tertiary prevention, depend on the caries and size of the caries and the management of the caries, and that we have and that we will find in the future. So I think that the SDF is one of the options that is very practical and maybe affordable and also maybe acceptable for everybody in the future. Thank you.
Thank you. CH, what would be your take-home messages for the dental community?
From our own experience, I would say first, use 38% SDF even though you are managing very young children. Don't use 12%. This is the first. The second is SDF is a very effective agent, but that need to be complemented with good oral hygiene and also a control of the carcinogenic diet. This is the second point that I think it is important for the children and the parents to know. And finally, from our experience, is parents and also children acceptance is extremely high if you get them well informed of the benefit and the complication of the treatment. That is the key points that I want to share.
Thank you. Rick, what would be your take-home messages?
Mine are three, actually one. It goes from 3 to 1. SDF meets healthcare's triple aim. That is that it significantly improves health, it's high quality, and it reduces costs.
Very distinct, thank you. Jeff, take-home messages?
Thanks, Rowan. Well, my experience is that it's much slower to be taken up amongst private dentists as it is in the health system. Community, the public health system, where there's budgets and an overwhelming number of patients to treat. SDF will integrate into this system really successfully. And if the public health system take it up and do across the board protocol, as I said before, of making sure that people don't need to leave the emergency clinic with any active caries, of ability to reduce GAs in small children. This idea will gradually become it'll save the government coffers a lot of money, but to seeing it done so successfully in the public system will then sort of bring it into the private system and see it done as a standard treatment of care, because I think the pharmacological management of caries is certainly the way that we should be all going.
Good, thank you. Well, my role as chair is to summarize some of the take-home messages. For me, this has been an important webinar. I think the place for traditional school-based programs where mobile units are taken and traditional care is placed in schools really is outdated. And I think the work coming from New York is showing us clearly that there should be a radically new approach to community-based school programs. I think Hong Kong has taught us that silver diamine fluoride, whether we call it the magic solution, a dental vaccination, has the ability to attract community support. And in Hong Kong, we've seen from politicians to funding agencies to rally round that when the benefits are seen, that they want to do this across the whole of the island. It also has the ability to attract irregular users or people who don't traditionally take their children to the dentist, of very young children. And so SDF has an effect to actually bring those people to a pathway of a dental home. I think also the silver ART is a very attractive proposition and has now really succeeded or supplemented the traditional ART approach. And I think silver ART should get a lot more attention and research and some of the clinical findings. But I think, Jeff, you raised in Australia this radical reduction or an almost elimination of general anesthetic of young children who have dental extractions or treatment. Stopping the decay young and reducing pain and sepsis is, I think, one of the things that's going to attract a lot more attention for SDF. We haven't tackled the clinical situations, but there are lots of situations where, whether you're in the public sector or the private sector, dealing with fragile senior people, people with dementia, people with in hospitals with chronic illnesses, any situation where caries management has to be done simply and just by resting rather than the traditional restorative approach, SDF has got to be one of the frontline procedures that we have in dentistry. I'm sure there's many other things to be said, but at this stage, I'm drawing this webinar to a close and want to thank a number of people. First of all, I want to thank our speakers, who some have got up very early in the morning and some have stayed very late at night. So I want to say thank you very much for this stimulating conversation. I also want to thank the sponsors of the University of Geneva, the Global Child Dental Fund, and Colgate-Palmolive. this has grown. We had a limit of 500 people who could register for this webinar, and we have exceeded that already. So there is a growing attention and a growing interest in silver dynamine fluoride. And I'm sure this will just be the first of many seminars and webinars that will look at different aspects of dental care for different types of population. So thank you all very much. I draw your attention to next slide, please, that we have a webinar in next week, which will be talking about daily toothbrushing in schools from a number of different parts of the world. And then on the 15th of November, we have a discussion about the importance of integrating general and oral health. In 2020, we will announce a whole series of new webinars. But again, thank you all very much again. Thank you for all who participated. Thank you for the team in Geneva and all who've done the logistics for this webinar. And so with that, I call this webinar to a close. Thank you all again very much. Bye-bye.